So I want to welcome everyone tonight for our first webinar that we have for seniors and for their caregivers. We said the basics. This is the beginning of a two-part series. The next series will be in 2 weeks, November 24th. So if you didn't register for it or you're not sure, please save the date. And if you like this, please tell your friends. And we hope to have more programs such as this. I want to just do a quick introduction. My name is Harriet Blank. I work for OHEL Children's Home and Family Services, and I'm the director of our geriatric programs at OHEL. So I want to welcome you. And just a quick beginning, because I know you want to hear much more from the speakers. So 82 years ago marks the beginning. Today marks the 82nd anniversary of Kristallnacht, a date that changed the lives of many of our families forever. The world stood by and we lost so many. Today we remember the past and we remind everyone that we can't and won't stand by. We at OHEL and our colleagues work to preserve and care for the needs and dignity of our Holocaust survivors and their caregivers. Our programs span all ages, whether it is a trauma due to California wildfires, natural disasters, or even the COVID crisis, or just everyday people dealing with everyday life. Here at OHEL, we have a program, a professional, a resource. We are a community that cares. OHEL is proud to partner with our colleagues, and we look forward to an informative evening. And before I introduce my colleagues, I just want to do a little housekeeping. So tonight, I'm going to be acting as the moderator. That means I'm the timekeeper. We are going to keep everybody muted so that the speakers will have their ability to speak clearly and without having any interruptions. We are asking people to hold questions till the end. We will get to everyone's questions, no matter how long it takes. And if people need to sign off, we will certainly, if we have everyone's email, we'll email you or call you back with the answer. I promise you that. So just so everyone knows that piece, don't worry. And especially also if someone couldn't stay for a question, you can just say, can you please send me an email? We are recording tonight's webinar so that it will be available. And again, we want to spread the word. We, of course, at the end, I'm just going to give some more thank yous, especially to the JFNA who funded this program. So without further ado, though, we do have the chat. I want to introduce our speakers. And I think I'm going to introduce both people at the same time just to kind of break in, and though I might spend a minute with the next speaker if I decide to shorten it. So our first speaker is Dr. Vera Beckus. And one of the things, as before I even give her biography, is I'm very happy that on both webinars, we have both the psychological piece, which is so important for caregivers, as well as some concrete entitlement kind of nuts and bolts issues that people need, whether it be home care or legal plannings, because there's no way to really manage being a senior, being a caregiver, without having the whole picture, and it has many, many parts. Dr. Bekes is a clinical psychologist and an assistant professor of clinical psychology and co-director of the psychodynamic training track at Furkhout Graduate School of Psychology, Yeshiva University. Her research focuses on trauma in general, the Holocaust trauma, and transgenerational trauma transmission, as well as the change process in psychotherapy. She also has published extensively on these topics. She teaches psychodynamic, multiculturalism, and qualitative research courses, as well as she leads a research lab on PTSD, post-traumatic stress syndrome, resilience, social and transgenerational trauma. She also worked with Holocaust survivors and their offspring in the hospice unit of the Jewish hospital in Budapest, as well as provided psychotherapy in survivors' homes. I think I am going to divide the introduction, and I will wait to introduce Rabbi Schreier when it's his turn to speak. So without further ado, I remind everyone to stay muted, put in your questions, listen, because you're going to learn an awful lot tonight. So without further ado, Dr. Beckus.
Hi, thank you so much for the introduction, and hi and welcome everyone. I do hope you will learn some tonight, and whatever I'm not talking about that you would like to know, as Harriet said, you will have opportunity to ask questions after the presentation, after the second presentation, so at the very end. In terms of timing, if I understand it well, the questions will be at 9 o'clock, 9 to 9:30. So if you have to leave at any point, and you can always return to ask questions. And I'm very glad to be here. As it was mentioned, I'm really interested in the Holocaust trauma and in transgenerational trauma, and I did a lot of research. But today I will be talking about seniors and Holocaust survivors, as this was the topic of the invitation. So the transgenerational part might not get so much focus tonight, just to manage the expectations. Let me just share my screen to show the presentation. So I will be using a PowerPoint presentation, and I understand that everybody is muted, but please, if you have questions, just take notes, and then I will try to answer all of them afterwards. I'm just checking the time. All right, so the topic of today's presentation will be how the pandemic affects Holocaust survivors and seniors. And I will be talking about first older adults and the pandemic, then a little bit about Holocaust survivors, and then about mental health during the pandemic and what research findings show about seniors and Holocaust survivors, how they are doing during the pandemic. Then I will mention the vulnerability factors that we learned from research, and also the resiliency factors. And a couple of suggestions of how to promote resilience and strengths. So let's just first have a look of how older adults are doing in general, mental health-wise. So we know that it's very common in older adults to have all kinds of mental health issues. Approximately 15% of adults above 60 years old suffer from some kind of mental disorder. In terms of psychological disorder, besides dementia, depression is the most prevalent, and it's about 7% of older adults who are suffering from depression. Mental and physical health are interrelated. We will talk about a little bit more about this later. So what happens during a pandemic with older adults? So we know the factors. Higher mortality rate characterizes older adults, so they tend to worry more about their health with good reason. The self-isolation, the social distancing rules are really taxing for older adults. They can miss relatives, friends. They are not meeting with their social circles if they had before, and if they had limited social contacts before, it is even more reduced. Even if they are meeting and they need to keep the social distancing rules, it's really different from a normal, regular meeting. The pandemic really imposes significant changes in the daily routines, and these changes can be really challenging to deal with. The self-isolation and social distancing really limits the physical activities that one can engage, and this has a detrimental impact in not only the physical but the mental health of everyone, and especially older adults. The psychological aspect of depending on others, a sense of loss of freedom of doing whatever one feels to do, also is really taxing psychologically. I already mentioned this kind of sense of separation from friends, family members, which is a central issue during the pandemic. And of course, people are worried about their friends, their aging friends, and miss meeting with their children and grandchildren and wonder how they are. And many people say that it's a wonderful thing that we have the technology, which is really, really great, but it is still very often a problem with seniors, that they have limited access and limited skills to use internet and technology, which just increases isolation And also if they manage to use Facebook and video chat to meet friends and especially family and children, grandchildren, it's really not a real substitute for the physical sense of meeting with somebody. And always there is technical issues. You all know it's not just for the seniors, but it's really hard to troubleshoot if one is less experienced with technology. So all these factors contribute to an increased risk to develop mental health problems and disorders. And for those who already suffer from any kind of mental health problems, so we saw that it's really prevalent that elderly people can suffer from depression and other mental health issues, they can get worse due to these circumstances. And these mental health issues in return can have a negative impact on cognitive and emotional function. It can negatively impact how people can concentrate. They can be irritable and hedonic, meaning that they don't experience joy and happiness. So what do we know about Holocaust survivors? So the previous slide was in general about seniors during the COVID. What do we know about Holocaust survivors and how they are doing? We know that the Holocaust, even though it ended historically, it still has a psychological impact. It has long-term consequences on the mental and physical health of survivors. Many studies showed that psychologically, almost half of the survivors had PTSD symptoms 50 years later. So this was a study shortly after 2000, which is now old, but still after 50 years, they show that PTSD was still very prevalent. Later on, so this is a relatively recent study in 2010, so 10 years ago, Beryl and his colleagues conducted a meta-analysis where they just put together all the studies about how Holocaust survivors were doing and kind of analyze across studies, what do we finally know? So what they found was that it is true that Holocaust survivors still have much more post-traumatic symptoms than any other control group that they used in the different studies. However, they had no other mental health difference on other aspects. So there was no difference in depression, anxiety, anything else that they measured. There was one other important result, that there is this kind of sensitivity to stressors, which is true, by the way, to other trauma survivors, that they might cope really well, but later on when something extremely stressful happens again, for example, a cancer diagnosis or something, an accident with a loved one, they respond more strongly. So there is this vulnerability to give a stronger reaction to stressful life events later. But overall, it seems that despite these vulnerabilities, Holocaust survivors are really surprisingly resilient. And also that this kind of resilience, general resilience, coexists with the specific vulnerability to experience post-traumatic symptoms and to give stronger reactions to stressful life events. What do we know about survivors during the pandemic? So we know that they are above 75 years old now, right? If they were born before 1945, they must be above 75 years old. So it's a really aging population. They have various health conditions, and they can be at greater risk of morbidity and mortality due to the COVID. They can be really vulnerable because, as I said, so because of the previous traumatic experiences, the new stressful experience of the lockdown and isolation may trigger this kind of sensitivity and traumatic memories as well. So there are parallels between the present experience of not being able to leave the apartment, not being free to do whatever they want to do. It can be associated to wartime restrictions in the ghettos or in the camps, and brings back this kind of feelings of uncertainty and fear and helplessness. This is a quote from an interview with a Holocaust survivor, how he is feeling during the pandemic. And I think that this is a really good example of how many Holocaust survivors are feeling. So this the interviewer asks, what about the pandemic that bothers you the most? And he says, it is the unknown. I don't know what's going to happen. And not knowing makes me imagine all kinds of things. I'm seeing in my mind's eyes scenes of the Holocaust, when we did without food and necessities. I know I shouldn't be comparing the two because the privation and the problems now and those that we had during the Holocaust are diametrically different. But who knows? This situation we are in might all change for the worse. That's what I'm worried about. So this really captures this sense of uncertainty and helplessness of not knowing what will happen, which obviously triggers a lot of anxiety. Okay, so in this next slide, I really would like to raise the question whether older adults are really more vulnerable to develop mental health problems during the pandemic. So it would be very logical. So based on what we know pre-pandemic about older adults and survivors, we see that social disconnection in general really puts older people at greater risk of depression and anxiety. We have social disconnection during the pandemic. We know that past trauma makes people more vulnerable when they are experiencing present stress. So that's also present. We know that less physical activity across ages is really significantly relates to experiencing depression. Change in the routine is especially hard for older people. So all these factors would show into the direction that they might suffer more during the pandemic. So as an assistant professor, what do? I, of course, look at the research and I try to conduct research to find what is out there. And there are studies already out about how older people are doing during the pandemic. So let's see what they are saying. So there is a huge study that included about 15,000 people, among those older adults above age 60. They looked at how the older adults' mental health during the pandemic compares to younger people. And they included only the participants who had no mental health problems before the pandemic. So these are people who were psychologically healthy when they went into the pandemic. And this is what they found. So this chart shows 4 categories. The first, the gray category, refers to women above 60. So these are the older women category. We see that they have about 50% has severe emotional distress. So half of the women in the elderly or older adult group experienced emotional distress during the pandemic. The next group, so this is the comparison group, this is the younger women, so women below 60 with this orange color. And we see that it's higher. So the younger women experience emotional distress more often during the pandemic. So it's more than 70%. So we see, yeah, so this is correct. So the older adults experience less distress during the pandemic than the younger counterparts. So let's see the male participants. This yellowish colored column shows the men above 60. They experience distress about 34%. But when we look at the younger people, younger men, they experience more. They have about 50% experiences distress. So this is really a surprising finding because we would expect that older people must suffer much more and they must have more distress because of all the factors that we talked about before. But this huge study found the opposite. We also see that there is a huge difference in gender, right? That women have much more distress than men. So let's see how they explain the findings. So they looked at various factors of how come that people experience distress and then depression and anxiety. And one of the huge contributors was disconnectedness, a sense of not having a social network, not meeting people, loved ones frequently. And then it results in a sense of isolation. People feel lonely, they think that other people are not there for them. And this leads to depression and anxiety. So this was the pathway that the researchers in this study found, that this was the most important factor, a sense of disconnectedness, which led to a sense of isolation, and that led to depression and anxiety. It is important to note that the disconnectedness itself, so just the fact that someone has a very small social network, so if they have two good friends that they don't have very frequent interaction with, but they still feel that those friends are very close and they are ready to help whenever it would be needed, then it doesn't lead to depression and anxiety. So all factors had to be there. So there has to be a sense that, oh, I have a really small circle of people and that they are not really there for me, then people will develop depression and anxiety. Okay. So what other things did they find? They looked at how people react to psychological distress. So we saw that 50 and 70% of people experienced high levels of psychological distress. How do they respond? And I only included the older adults' responses, and there were two very important reactions were identified. The first was avoidant behavior. This was more prevalent in women than in men, but let's say every third or fourth person used avoidance behavior. What does it mean? Avoidance behavior means that we do whatever it takes not to think, not to talk about what stresses us. Right? And sometimes it can be helpful when it's really, really overwhelming and too much, but on the long run, it's usually not a very adaptive coping, because we just cannot avoid all the stressors. It will still be on our mind constantly, and it will have this kind of stressful impact, even if we try to avoid it. The second reaction was just plain depression. So this kind of low mood, hopelessness, sense of helplessness. So these were the two big reactions. So this was this huge study. What have we learned from that? First, we learned that there is high percentage of emotional stressors in older adults, especially in women. However, we also learned that older adults were at lower risk of developing depressive and stress consequences during the pandemic. We also learned that loneliness and isolation is an important risk factor. Okay, so let's look at what other studies say. One study, as we say, is no study, right? You have to repeat the study because one study can go wrong and just show very weird things. But no, so this result has been repeated across several studies during the pandemic. My colleagues and me also launched a huge study with international participants from all over the world. We were really interested again to what kind of symptoms people are experiencing, how they cope with the pandemic, how they are feeling. I checked the results for age and I found exactly the same. So I found that depression, anxiety, and PTSD symptoms were significantly lower in people above 65 years old compared to younger people. And also participants who were older, about 65 years old, experienced higher well-being than younger participants, which is so confusing. So how is it possible? So first, we have to remember that when we are talking about older people experiencing less distress, it's a comparison. It might not mean that older people in fact experience little distress. It also means that younger people experience a lot of distress. And these are the numbers across all ages. So this is, and this has been repeated again in a number of studies, that around 30% of people experience anxiety, depression, and PTSS. So PTSS means post-traumatic stress symptoms. So not disorder, which would be a really diagnostic category, but post-traumatic symptoms. So this is across all ages. This is the typical experience. So every about third person experiences acute levels of anxiety or depression or post-traumatic symptoms. From these, of course, these are overlapping categories. So very often if someone has post-traumatic symptoms, of course, they also have anxiety or they feel depressed, and any combination could exist. But it's important to remember that really these numbers are very, very, very high. So older people might not experience so little distress, but only in comparison with younger people. So younger people are at more risk to develop psychological distress and psychological conditions, mental health issues. Okay, so we understand that this is a comparison. It doesn't mean that it's not high, the distress is not high among adults, older adults. So what other factors can be there? So first, younger people are very often stressed about their present situation, their future, their employment, having to take care of children at home, homeschooling them, may experience financial problems, instability of their living conditions. Where will they live? Will they go back to their parents? Which country do they go if school is online, for example? So there are very specific concerns that just don't apply to older adults. They don't have these kind of concerns anymore necessarily. So there are very specific concerns that are prevalent among younger participants. Also, it's true, and research shows that this is really the case, that people just get really more wise with age. So they get better coping strategies, they have better defense mechanisms, they are able to cope with life's challenges much more better than younger people, because they learned what is important, what is not important, and how to cope with all kinds of difficulties. They also remember previous crises and how all passed, and how this is not the end of the world. They saw similar things. They see so many times worse thing than this. Also, it is important to remember that we have no data about how older adults will deal with the pandemic on the long run, what kind of consequences there will be. We really just don't have data. What we have data for is how they are doing now. This is, again, just quoting another factor that might play in a role in these findings of older people doing relatively better compared to their younger counterparts during the pandemic. So this is a huge study, again, across 160 countries, a longitudinal study. It showed that there is this U-shaped relationship between well-being and age, which means that the lowest well-being, so people feel the most miserable when they are in their middle age, like 45 to 56 years old. That's really a hard time. It seems that this is somehow an age when well-being drops, and after that, people's well-being, a general life satisfaction goes upwards. So they feel better by that time. So we also know that chronic physical conditions reduce this kind of aspect of well-being. So if people suffer from chronic physical illnesses, it leads to more depressed mood and less well-being in general. If you look at the left side of the slide, you see that well-being has three components. The first is evaluative well-being, which is about life satisfaction, how satisfied one is with their life. The second is eudaimonic well-being, a sense of purpose and meaning in life. And the third one is hedonic well-being. It's a feelings of happiness, sadness, and so on. So in order to have a good level of well-being, one needs all these, right? One needs to feel that they have a satisfying life, that there is a purpose, there is a meaning for their lives, and on the daily basis, they just feel good, like they can be happy about minor events during the day. So this kind of subjective sense of joy and enjoyment. And I just go back to the other side of the slide. So we know that well-being is such a central thing that impacts
Unmute.
I'm on mute. I don't see it.
You're not supposed to be. It's Harriet. I don't think you're supposed to be muted.
But am I? Can you hear me?
Yes, we can hear you.
Oh, okay. Oh, great. Okay. Thank you. Okay. So where were we? Yes, so well-being. So how important well-being is for the physical health as well. So not just feeling psychologically well, but also for the physical health. Studies showed that people, you can see the numbers, it's not that important, but the main point is that when people have a meaning, sense of meaning.
What's high for a stupid apple?
Whoever's not muted, please mute yourselves besides the presenter.
Thank you. Yes, it's so tricky with the.
That's technology.
I know, yeah. We are talking about that, right? Okay, let me go back to the big screen. Okay, maybe this is better. Okay, so well-being impacts really the length of life. So people who find meaning, who are happier on a daily basis, live longer, very simply put. And this association between well-being and just survival is independent of age, gender, demographic factor, baseline mental and physical health. So this has been a really universal finding. Okay, so what have we learned from all these studies? So first, what puts people to risk of experiencing mental health problems, high distress? Female gender is an important factor. By the way, being female puts people at risk to experience all kinds of mental health issues for various social reasons of, you know, how we are allowed to express emotions, how women are more accepted to show emotions, negative emotions, and so on. There are a lot of factors contributing to that, but this is true to older age as well. Female gender is associated with greater risk. Of course, previous mental health disorder is a risk factor during the pandemic because stress is always more difficult to handle when someone already has kind of a baseline default stressful situation. And mental health disorders often also mean that people are having a hard time to deal with stress in general. So if somebody already had a depression, then during the pandemic, probably it's difficult. Although sometimes I hear like just case examples that people feel relieved during the pandemic because of previous depressive feelings, anxiety, because they are just not exposed to that many stressors. They don't have to interact with other people. They can just stay home. They don't have to engage in activities that they wouldn't want to, and that would trigger their negative feelings and so on. So it's a complex question, but usually the general notion is that previous mental health disorder is a risk factor. COVID fear and health worry, as we mentioned, in older adults, it's a natural thing and it's a rational reaction given the higher morbidity and mortality, but this kind of elevated risk, this stress also is associated with more distress and risk of developing mental health problems. Perceived ageism has been described as well as having a negative impact on older adults' mental health. Reading on social media these kind of narratives when they feel that they put a strain on society, and people are restricted in their activities because they are trying to protect them, and sometimes this can be really hard to take and perceive. Previous trauma is a known risk factor. As already mentioned, people are with trauma history, either Holocaust trauma, but also childhood trauma or any kind of trauma, are usually more vulnerable to later traumas, to react strongly to strong newer stressors, because there is just this sensitivity and the reminders of the previous trauma. Transgenerational trauma is also an important factor. We relatively talk transgenerational trauma, relatively little talk is going on about transgenerational trauma and its impact, but I think it's really an important topic, and I'm trying to promote the idea and the research findings regarding transgenerational trauma and how, without experiencing the trauma, for example, the Holocaust trauma, by ourselves, it still can impact several generations and make them sensitive to newer stressors, very often even without the offspring being aware that their stress are related to the original Holocaust trauma. We already mentioned that living alone and feeling isolated and lonely is a major risk factor. And also there is another topic that we haven't mentioned yet. It's if someone loses a loved one during the pandemic. So because very often there is no opportunity to grieve and to go through the rituals, to go to the funeral and so on, it often leads to a prolonged bereavement, and it can also put a strain on the person's mental health. And now, in terms of what to do with all this that we have learned from research. So a central idea is this resilience and strengths-based approach. So instead of focusing on what goes wrong and what is weakness and what is a risk factor, really focusing on strengthening the skills and the coping of the older adults. So resilience is really, we can imagine it's like a ball that we just squeeze and it just bounces back. So this is how we can imagine psychological resilience. It's an ability to bounce back kind of after experiencing adversity, trauma, tragedy, threats, or significant sources of stress. Resilience is something, it's a skill that can be developed and improved. And interestingly, among older adults, resilience is very often stronger than in younger adults, especially regarding to emotional regulation and problem solving, which just means that when something unexpected, negative happens, older people very often can take it a bit, taken aback and not jump on it and react emotionally very strongly. And then to process the events in a more wise, balanced way. These are general statements, and everybody is different, and some people are just very impulsive when they are older, but usually the tendency is that impulsivity and these kind of very extreme emotions usually get more balanced with age. So this is the general tendency.
Excuse me, the time, can you hear me?
Yes.
Okay, so the timekeeper is telling you 5 more minutes.
Okay.
Thank you.
Okay. All right. So as I said, that these are just generalities, and of course there are a lot of. So again, what the Holocaust survivors, we talked about that there is a huge range of possibilities how survivors are, but many survivors are really hard. They see themselves as examples of survival and resilience, and they understand that despite there is a crisis that might remind them to the Holocaust, they have opportunities to go out. It's really different from what they experienced during the Holocaust. They can still speak to other people, even if it's through a window or a phone or online or a screen, and that this situation is temporary and it will pass. So there is a lot of resilience among Holocaust survivors, and as I mentioned, we don't know still the long-term effects of the isolation on the Holocaust survivors' mental health and well-being, or in general in older people's mental health and well-being. Unhelpful strategies. So first I will go through the unhelpful strategies in general based on these findings, and then I will suggest a couple of helpful strategies. So what is really not helpful? It's not helpful to emphasize the vulnerabilities of older adults. It's also not helpful to treat them as a homogeneous, fragile population with no agency. It's not helpful to disregard strengths, resilience, and abilities. And I already mentioned this ageist and paternalistic attitudes that sometimes is present in social media. These are really, really unhelpful approaches. What could be helpful? So this would be a strengths-based approach, when we encourage older adults to really optimize their skills, use the resources they already have to be able to cope effectively with the situation that we live in. As mentioned, it's really crucial to reduce the isolation. So even if just arranging a phone call every second day, just 5 minutes with their children or grandchildren, it means so much. It can change the whole perspective. Physical activity at any age, but in older adults is especially important, and it has a huge positive impact on mental health and on the mood. Behavior activation is a general psychotherapy term, which means to encourage older adults to do things they find joy in or meaning in. So we mentioned well-being, so any activity that can bring any aspects of the well-being could have a huge impact. So it seems tiny little, but it has a huge impact on how they are feeling. There are internet, phone-based remote interventions, of course, available if somebody is already experiencing mental health problems. There are other suggestions like exercising gratitude, thinking about the good things that are still there, connecting to nature, and in general, just to allow what they feel and support them. So thank you very much. You can see my email if you would like to reach out and have any question. And then I'm happy to answer any questions you might have after the second presentation at 9.
Okay, well, I certainly have some questions, and I got a couple of questions for people. So I hope everybody's going to stay and listen to hear some of the questions, because they might be questions you might have thought of, certainly questions I thought of, and I really do appreciate all that good work, and it's certainly food for thought. So I want to go to the next presenter here. We're going to be shifting gears in a way, because now we're going to be talking about home care. And our next presenter is Rabbi Ashie Schreier. And Rabbi Ashie Schreier is the director of the private pay division and a staffing coordinator at Caring Professionals, a licensed home health care agency serving the New York community. In addition, he serves as the spiritual leader of the Young Israel of Forest Hills. Rabbi Schreier is a graduate of Yeshiva University in Reitz, and holds a master's in accounting and an MBA in healthcare administration. And again, questions at the end. And I welcome Rabbi Schreier.
Okay, thank you so much for this opportunity. It's really always an honor to be working with OHEL. You guys do such incredible things. Getting to see Harriet in action, got to meet with her in the office a little bit ago. It's really something special and really something truly inspiring to see. And really just even to arrange this this whole night, this whole event. Bracha, thank you so much. Got to give a shout out to my Aunt Mimi as you're on here. And the first presenter, I mean, that was just incredible, especially so relevant to everything that's going on now, aside from the home care hat. So as Harriet mentioned, I have the Rabbi hat also, and something that's just been coming up over and over again is just during this crazy time period which we find ourselves in, which hopefully we will be on the other side of very soon. It's just the loneliness and the depression and everything going on. So it's so important, so relevant, and really so much appreciated. So I learned a tremendous amount, even if just for that was great. And so it's really been awesome so far. So not great act to follow, but we'll do our best. So I like to start out these types of talks. There's a lot of practical elements that are going to have to be discussed because it's a bit of a totally new parsha, as they say. It's a totally new entity going into the home care world. I take it for granted that I interact with it every single day, but I talk to people all the time who are just having a loved one that unfortunately fell down or is going through some sort of difficult time physically, that all of a sudden they're now thrust into a position where they need to organize home care. And it's just a bit overwhelming. There's a lot to discuss. So I want to take a step back. The way I like to view things, I guess it's the rabbi element. We start from, we'll look at the Torah perspective for a minute, and then we will go into the practical elements. And I'm definitely biased in terms of my love of home care, but I've always been fascinated by the home care elements and the end-of-life situations that come up from our greatest leaders from and throughout the Torah. So you see Aaron HaKohen, the brother of Moses, the brother of Moshe Rabbeinu. So he has this death that was just so wanted by Moshe Rabbeinu. It was so pleasant. It was exactly the way anyone would want to go. Again, that's not going to be the focus of our talk tonight, but it was known as Neshika. It was such a pleasant way to go. And Moshe Rabbeinu himself said, God, I would love to have this type of thing where everything is in place and everything is pleasant. There's no pain. It's kind of just going in as smooth a way as is possible. And we see the end of lives of a lot of our leaders, but I always like to focus on Yaakov Avinu, on Jacob, the last of our forefathers. We're reading about Abraham, Isaac, and Jacob, Avram, Yitzchak, and Yaakov. But when we get to Yaakov, we find something very interesting because he was really the first person to ever get sick. Chazal teach us, and the rabbis teach, that before Jacob, before Yaakov Avinu, people would just sneeze. They would sneeze and that would be it. This is why we say, like, God bless you, or Gesundheit. That's one of the sources for it, because it used to be you sneeze and you were dead. Now, Baruch Hashem, and thank God that is not the case. People sneeze and, or I've seen people sneeze a lot of times in a row, it happens. But we sneeze and it's okay. But Yaakov was the first person to ever get sick. And what happened was he wanted to get a chance to know when things, I guess, were coming to an end or when he was going to be on his last days. So he was the first person to ever be sick. And you find that he was in his own home. Now, he wasn't in the place where he ideally wanted to be. He was in Egypt, but he was surrounded by his children, surrounded by his family, got to be in his familiar setting where he was for the last bunch of years. And he really got to go in his own home. He got to be surrounded by things which were familiar to him. And he got to be in a place where he was comfortable. And this is just something which is an incredible blessing. It's something which we are lucky that we have the power to have nowadays. The access to the different medical supplies and the medical capabilities that we have in the home now is different than we've ever had, and it's more enhanced than we've ever had. Now, there are specific rules in terms of New York stuff. We're going to get to that in just a minute of more of the details, but just recognizing the concept of the home is something which is a very powerful thing. When someone, after 120 years, passes away, so we have what's called Shiva, and you go and there's a mourning period, obviously, so the 7 days, whatever it may be. And when people go, they say this phrase of Hamakom Yenachem Eslem, that the place should be a consolation for you in terms of trying to console the loved one of the person who was just deceased. And many people ask, it's a very strange word that we use, Hamakom. We're referring to God as the place, and it's a very strange phraseology in terms of referring to God. What exactly is it that we are trying to get at? So I once heard, my grandfather's been in the healthcare business for a lot of years as well, and he was explaining to me that a lot of times you say Hamakom Yenachem because the place should be a consolation. A lot of times, or most of the time, when someone is in that mourning period, you'll find that they are in the home of the deceased, and that's where the family is sitting. It could be that a bunch of siblings are sitting together, a bunch of children are sitting together, whatever it may be, but you say that the home is a consolation because your home really represents you. Your home defines you. You know, they did a feature on some of the great rabbis and some great people in various places, and what they did was they just went through their house and showed what's displayed in their house and what's hanging in their house and what's really happening in their house, because that really shows what you value. You create that over your lifetime, and that is something that you get to interact with in a very intimate way. So hamakom minachim, that the home is going to be something which consoles you, that's because you really get to celebrate the life of the person in the home. Now, again, we are very lucky that we live in a time of modern technology and medicine that allows people to live a lot longer than they ever have before. And also, we live in a time where people are able to age at home. And aging at home is something which, again, has so many advantages to it. Being able to be in the place where you've been for so many years, or even if it's newer, whatever it may be, but being to sleep in your own bed, being able to be with things that are familiar to you. As people get older and the various diseases and sicknesses that come up, familiarity is so crucial, making sure that you have the same kind of routines, the same kind of things happening. That is really so crucial in everything that we are doing. And all the research shows that it's true for mental health, for physical health. Having things which are familiar to you is something which is so important to do. But again, it comes up very fast sometimes. Unfortunately, things just creep up on us. It's not fun or exciting to prepare for this stage, whether it's for us or for a loved one or whatever it may be, but it's so important to make sure that we at least have the lingo down so we can somewhat know what we're talking about. After tonight, the goal is not to be an expert and go into the Medicaid offices and, just go and fighting out certain things. The goal is that you have a basic understanding of a lot of the terms and concepts which come up, to know what you are and are not entitled to know maybe someone's been paying into a policy for all these years and you just don't even know what you're paying into. You don't know what you're entitled to, and all that money goes to waste, and all of those benefits go to waste. So we're going to talk a lot about that. But there's a concept amongst, again, the rabbis, where it says, Kol hatchalot kashot. I think the professor, first speaker, was talking about this as well, that the new things bring upon anxiety. And it's something which is very difficult, and especially during this crazy time which we are living through, it's a very hard thing to do, and introducing new things is very difficult, especially at later stages in life. And really dealing with home care, starting from the beginning, it's kol hatchalot kashot, that the beginnings are very difficult. And I once heard a beautiful explanation that the problem is also the solution. When it says kol hatchalot kashot, that the beginnings are very hard and difficult, so the answer to that, what we have to do is be kasher. You need to be difficult. You need to ask questions. You need to be a nudge a little bit. You got to try to make sure that you are as informed as possible in order to make sure that you can go ahead and get the best care possible, in order that you can make the best out of this new situation which is coming up. Now, again, it's not always so pleasant to go ahead and be preparing for these types of things, but even just to have a working definition of a lot of the various things it's just so crucial to know what, again, you are entitled to, what you're not entitled to, how it would work and where it would work and who it would come from. And again, this is not necessarily a pitch for our company. There are tons of home care agencies, but anyone should just have everyone should have a basic understanding of what they're entitled to, of what's out there, and go from there. So let's get started. So what happens is, if someone has, let's say, a fall and they go to the hospital, or someone is at the stage where they feel they are ready for home care. So there are a bunch of different avenues that people can go to get home care. Number one, so there is Medicaid. If someone is able to get onto Medicaid, now to get onto Medicaid, the rules have actually just changed about a month ago, and it's going to be fully in effect in a few months. So there are a lot of Medicaid lawyers, there are a lot of elder care lawyers that deal with this. Our agency also deals with this. We help people get onto Medicaid. But getting onto Medicaid, you can put money into a trust. This is not a Medicaid talk, so I'm not going to focus too much on that. But there used to not be any look-back period, which means, someone could be making $1 million yesterday and then wanting to sign up for Medicaid tomorrow, and it would be okay. But now they look back a few months. So far, my only advice, at least in terms of wanting to get Medicaid, is do it soon, because the laws are going into effect soon and changing very soon. So if you plan on doing that, let's get in touch, or get in touch with an elder care lawyer and try to do that very soon. But assuming that someone is able to get onto Medicaid, and again, there are various methods to get people onto Medicaid. There are these trusts where you put your assets and your money into certain trusts, and then you are able to get Medicaid. So someone gets onto Medicaid and then they get approved. They get checked out by the Medicaid offices to get approved officially for the home care. And then they get signed in or signed up with what's called an MLTC, a managed long-term care company. So this is an MLTC under the Medicaid umbrella. It's called an MLTC, and there are a lot of different MLTCs. So what an MLTC would do, just to throw out some examples of some: Centers Plan for Healthy Living, Age Well of New York, VNS, Aetna, Elderser. I don't want to leave anyone out. There are more. They're all great, wonderful, great companies. So these are all the specific MLTCs. And what you would do with these, the MLTC sends out a nurse. They have some algorithms that are way beyond my pay grade that figure out how many hours that you are entitled to. And they then say, for the long term, because Medicaid is a long-term solution, for the long term, you are entitled to, let's say, 7 days, 7 hours. Let's just use that as a simple example. So 7 days, 7 hours, 49 hours per week. And that is everything going forward. That means that you are now entitled to that going forward for hopefully many, many years. And hopefully you will never need it. Hopefully all of this should be not practical. No one should need things. But again, it's not even something to think like that. It's not, you shouldn't think of, oh, I have a homemade now, I'm at a new stage. No, not necessarily. A lot of people, it's just helpful. It's nice to have help around the house. It's nice to have help in what you're doing. We'll talk about what the aides are supposed to be doing, but we'll get to that in just a minute. So you have this 7x7 case under Medicaid, under an MLTC. So you hear this phrase MLTC, you think Medicaid, now you know where that's coming from. So you have this 7x7 case. Then the MLTCs have contracts with a lot of different agencies. We are one of those agencies. Again, there are a lot of different agencies that have contracts with these MLTCs. You speak with a coordinator, you speak with people in the agency, and you try to find that right shidduch, right? You try to find that right match. That's really what it's all about, trying to find that person or those people that are going to be able to make your life a lot easier. And this is not something to feel guilty about. This is a nice thing of care. There's a reason why this is a big industry, because there's a lot of really good people out there who are out there in the field working. So one option, again, is to go through the home care, Medicaid, MLTC. You have a home aide there, 7 days, 7 hours, and that could be it. Now, if someone wants to get more hours, if you find that the situation is deteriorating a little bit, so you have the ability to appeal and to get reevaluated and all of those things. So you can always reach out to the MLTC and try to get more hours. But one piece of advice, I guess, that I've learned over my years is you can't be afraid to be annoying, I guess. You can't say, oh, I don't want to bother them. I don't want to ask so many times. No, be as annoying as possible and try to get it done, because once it's done and once it's set, you're good. So that's really what a very important goal would be. So that's one element of the Medicaid. You can have a home health attendant. You can have a home health aide there for the 7 days, 7 hours. A few years ago, probably 7, 8 years ago, they started a program called CDPAP, CDPAS, Consumer Directive System Program, whatever it's called. But CDPAP, this is another phrase that people should know. CDPAP is where people can take care of their own loved ones. You could take care of a family member. You could take care of a parent. You could take care of a grandparent. You can take care of a friend. You can take care of whoever it is. If you find someone, you can go and take care of them. You don't need the HHA certificate. If it's going to be someone through Medicaid, like the first case we discussed, then it's going to have to be a licensed home care attendant. So they would need, to be legal. They would need to have certain requirements of continued education. They would need to have an HHA certificate. So there are different schools that go and provide. It's like a 2-week school or whatever it may be. So various different requirements for needing a home health attendant. But when it comes to CDPAP, if someone wants to take care of their parent, if someone wants to take care of their friend, their grandparent, whoever it may be, so all you need is a physical, and then you could be the one to take care of your parent. So you can get paid $18 an hour for taking care of your loved one. It's something which is a really nice opportunity that people have taken great advantage of in a good way, meaning it's a wonderful opportunity for a lot of people, and that way you get even more familiarity, aside from staying in your own home. If your own child is able to take care of you and get paid for it, so it's a really nice thing. So that is another option within the Medicaid realm. That is only a Medicaid program. That's only something which is approved by Medicaid, but you have within Medicaid, the umbrella of Medicaid, you have CDPAP and you have regular home care. Medicaid, again, is long-term. So if someone feels they're going to need home care for a long time, it certainly pays to get onto Medicaid, because Medicaid is, again, long-term, and home care becomes very costly very quick. So it's something certainly to look into if you are going to be needing long-term home care. Now, when it comes to shorter term stuff, so let's play out the situation. Someone goes into the hospital and they had a fall, or someone goes to the doctor and they're just not doing so great. So the doctor will prescribe them, or the hospital will set them up. The social worker in the hospital should be setting them up with a CHA. This is what's known as a certified home health agency. It's called a CHA, C-H-H-A, and this is covered through Medicare. So now, anyone who is 65 years of age and up in New York qualifies for Medicare. So this, again, is government funded and is free. So you get referred to one of these CHAs, and they provide you short-term care. Now, within this short-term care, you get OT, PT, nurse visits, wound care. You get various different things that come along with all of this. You get all of the different benefits. And along with that comes about 5 days a week, 4 hours a day of home care, where you're able to get a home health attendant in the home. Again, short term, it's for about a month or two, depending on various assessments, but you're able to get that, and that's all through Medicare that you are able to get that type of care. So again, Medicaid is the long-term one. Medicare is the short-term one. Medicare, you don't really need to qualify for or put any money into any assets, into any trusts or anything. Medicare, anyone over 65 is entitled to Medicare after some sort of episode, which means either a hospital visit or a doctor's appointment where a doctor can write some sort of prescription. So very important to know, again, you are entitled to this short-term care. So if someone wants to get started but doesn't know if this is going to be something which is a great fit for them, or they don't know if they can afford it right away, or they don't know other sorts of plans, you should know that you have this in your back pocket to get started, and you are just about able to get started wherever you would be in New York with this type of care. Now, I know I'm throwing out a lot of terms and it's going a lot. I want to make sure to get everything in and just talk. We're going to make sure to review everything, and obviously questions are welcomed and always encouraged at the end. I don't think I'll take till 9 o'clock, so we'll be able to ask away earlier. But really, so I know it's a lot. We'll definitely make sure to review. So far we've done Medicaid and Medicare. Those are the two types of services that we've done. Next, the department that I run in Caring Professionals is the private pay department, which is where you pay for the services privately. Now, it's important to know, and again, this is not good for business for me to say this. I'm saying this because our goal is to help as many people as possible. That's the goal. There's different ways to go about getting private home care, especially in I know OHEL's 5 towns a lot based. In fact, there's a lot of WhatsApp groups and the this and the that, and different ways of getting someone into the home. So there are different benefits of getting an agency versus not getting an agency. With an agency, you're able to use your long-term care insurance, which we'll get to in a minute. Also, with an agency, you have someone just on top of the case. But the negative of the agency is that most of the time it's going to be more expensive than if you kind of found someone through, your local WhatsApp shul groups or whatever it may be. So certainly pros and cons on every end. So the private pay that we run, or that many agencies deal with. So this is where the patient pays privately for everything that they are going to want. So they can determine the hours, they can determine the days, they can determine everything that's going to happen. This is where there's a tremendous amount of flexibility because you are the one who is paying for everything. Along with that, I know we just started rolling out, and there are other people that rolled out as well, a sort of concierge service for our private patients. And a lot of people are doing this because it becomes very tricky when you just get so many phone numbers, you don't know who to call for what. It's just very difficult. So what we're trying to do, what a lot of people are trying to do, is just to be that one-stop shop for people, that if someone wants a chef or someone wants a nail salon, their nails done or their hair done or whatever it is. So we contract with all different types of people to try to figure out how we can set up that type of care for you in the home. The goal is to make your life as easy as possible, and that's what the agencies should be doing for the families. It's a partnership. It goes with the patient, the family, and the agency. They should all together be creating a partnership to make your life as easy as possible, because that is the goal of everything that we are trying to do. Now, it's important to know, if someone has long-term care insurance, that is under the umbrella of private pay. If someone's been paying, a lot of people have been paying into this, maybe there was a good opportunity a bunch of years ago where you can buy into a certain insurance policy. there's a lot of different long-term care insurances and a lot of different policies that people may have. You should know if you've been paying into it. If you have been paying into it, it's important to be in touch with them to find out what is necessary to start a case. And it's important to talk to them about what is necessary to get reimbursed, to figure out what needs to happen in order for us to get all of this plan active. Understand what it is that you are entitled to. A lot of different insurances and a lot of different plans have a lot of different details to them. So some people will be covered for $200 a day, some people for $300 a day, some people for 10 weeks, some people for 10 hours a day. A lot of different plans have a lot of different details, and it's very important that you figure out what it is that you are entitled to. Normally, you would have to work through an agency in order to be fully reimbursed for all of this stuff. So it's just important that you continue, that you open these lines of communication with the various companies that you've been involved with for all these years. I know I'm paying things. Sometimes I'm like, what is this even for? And it can be overwhelming because there are a lot of bills and you just get into a routine. Oh, okay, yeah, I assume I owe that, or I assume I've just been paying that. I don't even know what it is anymore. But it's very important that you know what it is that you are paying into so you can figure out what it is that is going on. Now, again, the goal of everything that we try to do is to find that proper shidduch, to find that right match for the family. It's not supposed to be something where it's forced, and it's not supposed to be something where it's just tremendously unpleasant. Obviously, each situation is different, but the goal is to have that this home attendant, that these people will be part of the family. I know I can talk from experience. I've had a few grandparents that have been on our service. And I remember we went out to lunch with my grandfather when he was when he had a specific home attendant, and my grandfather was a rabbi for a lot of years, and we went out for pizza, and right after we got all the pizza delivered to our table and we're about to start eating, the home attendant's like, no, wait, what is wrong? Everything okay? He's like, no, the rabbi didn't wash his hands yet. I'm like, wow, that is impressive, because I didn't even think of that, and none of us thought of that, but this is the home attendant. He's part of the family. He's part of the culture. He understands exactly what was going on, and they create a tremendous relationship. As the first presenter was pointing out, the professor was talking about just the loneliness and how difficult it is nowadays. We also have what's called a companion service, caring companions, and a lot of people have these types of companion services, which is basically just to have someone to combat loneliness. There's just so much loneliness out there, especially during this crazy time. So there's certainly what to be said in terms of trying your best to combat loneliness. If someone's, let's say, in the hospital, so you're not really allowed to have a home attendant in the hospital, but we send out companions that can stay with the patient overnight. The family needs to be able to live. Everyone's got lives that they have to live, jobs that they have to do, families they have to work with. And it's important that this is not something to feel guilty about. It's a very credible option and something certainly to think about. Now, to get into a bit of the details as to what a home attendant is supposed to do. I get this question all the time. So like, what are they going to do? What are they going to do? What are they supposed to do? How do I know what to tell them to do? So the basic roles of what a home attendant does, and in a normal situation, a nurse comes and does an assessment. So a nurse would do an assessment, and you're entitled to this through Medicaid. Medicare gives you this option. If you sign up with private pay, most agencies will provide a nurse to go ahead and do an assessment and create what's called a plan of care. So they create this plan of care. And normally the things that are checked off on this and the things that people are normally doing are what's known as the ADAs, the ADLs, the activities of daily living. So it's stuff like getting dressed and going to the bathroom and preparing meals and medication management and things like those. Those are the basic, laundry, shopping, accompanying to doctor's appointments. All of these things are the basic roles and duties of an aide. Obviously, there's more, there's less, depending on the situation, but those are the basic things which they are supposed to be doing. A lot of people nowadays have been thinking and talking about the role of COVID in terms of home care. Now, obviously, COVID has impacted everything and everyone, and home care is no different. So a lot of people have a bit of anxiety about letting new people into their home. How do I know where they've been? How do I know what they've been up to? And it's a great point. It's a great question. So it goes a little bit of both ways. On the one hand, it's nice to have more people around or new people around, so that way to combat the loneliness, but it's also, exposing into a new, bigger bubble. I'm not Rabbi Glad here, so, I don't know all the details about what's safe and what's not, but, introducing new people into the bubble is always something which is scary. So they ask, what are we going to do? How are we doing this? Do they test? So a lot of the aides do get tested, but we can't, no one can force them to constantly get tested. But what we do or what we can do is follow the CDC's guidelines and the Department of Health, which is we do the symptom checks every single day. So if anyone is not feeling well, they know not to be going into work. We also do the forms to make sure no one is traveling to any of the restricted areas. I know the rules keep changing. If you 3 days and then a test there and a test here and test there, a test everywhere, who knows? But a lot of rules, and they're all wonderful. Not ripping on any rules. They're great rules. I love them. But so we make sure to follow all the guidelines to make sure it is as safe as could be. So that is really the goal with COVID. Now, it's an interesting dynamic in terms of the home care business with COVID because, unfortunately, there was a lot of, what's the best way to say this? There's a lot of unfortunate events that took place in nursing homes, and hospitals were a bit dangerous, and rehabs people are afraid of. So a lot of people are afraid to go to a lot of these types of facilities because of just the COVID risk, because one COVID patient comes in and it becomes a scary situation because, a lot of these places are understaffed, or even if they're not understaffed, a lot of the staff is working for a lot of different people. So again, I'm not saying whether that's a valid thing or not. I don't work in a hospital, so I don't know anything about that. But a lot of people have some anxiety about being near any sort of facilities. So a lot of people just say, okay, we'll figure it out at home. We just want to be home. So it's important to know, again, what you are entitled to, because you could get all of these therapies and you could get a lot of these nurse visits and you could get a home health attendant in the home. So it's important to know what it is that you are entitled to. Now, we'll get back to the Medicaid thing in just a minute, but it's just something which when you understand what you are entitled to and you understand what you have in front of you and you're able to really properly navigate the system, it's a world of difference. So many people, they're just caught in this situation and they're being thrown out all these terms and this Medicare and Medicaid, and then all of a sudden they have a huge bill and they don't know what's going on. They don't know what's what. So even just taking the basics of what we just discussed is something which, again, is so crucial. So let's take a step back and review what we've discussed. And then I guess maybe we'll be done a little early. I don't think anyone will complain about that. So let's see. Except Harry. Harry, is that okay? I'm sorry. So we'll discuss. Well, let's go through it again. So again, we started from the Torah perspective. We're talking about some of our great leaders, Moshe and Aaron, and Yaakov is the one who, again, has the children around him. He's in his home. He was the first person to ever get sick and to really age in place and to be able to have this nicer, ending, this nicer element of being able to really have the sense of familiarity with him, to be able to have the consistency of the people, of the setting, and all things like that. And we discussed how powerful the home really is. The home really defines you. The home is what's the consolation if something were to happen, because you really are defined by the home. The home is something which is just your place of comfort. It's something which you've built and you've continued to work at in all that you do. And that is a comforting thing to be a part of. And we're lucky that we live in a generation, we live in a time where the technology exists, and you look at all these telehealth things, the technology exists where you're able to get care in the home. You're able to get all the various materials, something we didn't even mention under Medicaid and sometimes even through Medicare. You can get a hospital bed, you can get all the different materials that maybe you would have in a hospital, all the different devices that you'd have in a hospital, you're able to get them in the home as well. A lot of people have these bracelets or the buttons that you can click for Hatzel at any time or for the ambulances at any time. There are all these different gadgets out there that make the home a safer place. I know we just started, we have Rebbetzin Fagi Horowitz on our staff, and she is someone who just became a certified home inspector, that she goes into the home and makes a home assessment to figure out how to make the home as safe a place as possible in terms of the steps, in terms of the ramps, in terms of the lighting, in terms of the different gadgets. So that's something which is offered. I know we also have a social worker, and again, a lot of people do this. I can only talk from our company just because that's what I see, but I know a lot of people are doing this. We have social workers there that, can kind of be in the mix, in the thick of things to help the patients in every way. But again, whenever we need social work, Harriet's our go-to, and OHEL does just incredible work with so many. One thing I forgot to mention, which I was saving because of this setting, we have a JCC contract, which means that we have a separate unit in our company, and a lot of people do also, dedicated to survivors of the Holocaust. And, there's the money that's being paid from Germany that is being dedicated towards home care. So we contract with the JCC, and in the JCC, if someone's a survivor, they're entitled to certain benefits. So you should certainly look into that and call about that, because you may be entitled to benefits you don't even know about. So that is certainly something to think about. It's one of the more enriching parts. You get to talk to survivors, is hearing how they persevere through everything and continue to persevere. And it's something which is truly inspiring to watch. So again, we're lucky that we have the ability to have all this stuff at home, but again, it comes up fast and you need to be prepared for it. Kol hatchalot kashot, that all beginnings are difficult, and the way to combat that is to be kashet. The way to combat that is to be strong and steadfast, and make sure you're asking questions and make sure you're gaining knowledge and gaining insight into how this stuff works, because that's really the only way to combat the new beginnings being tough, because there's a lot of new terms out there. There's a lot of new phrases. There's a lot of new elements to all of this home care world that you need to be familiar with. And we went through some of the different umbrellas. We went through the Medicaid umbrella. That is for long-term care. If someone feels like this is going to be a long thing, it might be a worthwhile investment to get into Medicaid, because again, the costs creep up a little bit. And to be able to have Medicaid is something which is long-term. You get signed up with an MLTC, and you can either get home care through there after they come and assess how many hours and days they're going to give you, or you can get CDPAP, where you can take care of your own family member and get paid for that. So that's something which has been a very, very popular program for a lot of people for obvious reasons. You get to watch your mom, watch your grandma, whoever it is, and also make some money along the way. So that was the Medicaid. And my only piece of advice, again, if you're going to get onto Medicaid, do it soon, because it is things are changing. So it's important to get on there soon as you possibly can, and to do that as soon as possible, just because, again, the laws are changing and it's going to be a little more difficult to get onto Medicaid soon, but always something to think about, always something to look into. That is number one. Then we spoke about Medicare. Medicare, anyone 65 or above is entitled to Medicare after a hospital visit, a fall, or a doctor's visit, or anything along those lines. So you're able to go ahead and get short-term care, and that would include OT, PT, wound care, nurse visits, all those stuff, including a home health attendant for about 20 hours a week for about a month or two. It's certainly something to look into also. And you may be entitled to that even if, you just feel like it's time and you haven't had one of these episodes. You should definitely reach out to someone who would be able to direct you in the right way. My information will be here somewhere, I'm sure, or anyone can call Harriet and figure it out. But there's ways to find out if you're eligible for these things, but you should know that they will refer you to a CHA, a certified home health agency through Medicare. And then they contract with different companies like us that send home attendants, and they give you an OT and a PT, and again, all those different types of therapies that may be needed. So it's important to know that. And then it's important to know how private pay works, that you can pay for your own care and you can kind of custom make it to work with your schedule, to work with your life. You can have a live-in, you can have someone that sleeps over, you can have someone that's there for 12 hours, you can have someone that's there for 2 shifts, one person for day, one person for night. There are a lot of different options you can do. And it's important to know that you have options. If someone's been paying into long-term care insurance, you should make sure to figure that out, to know if you have been paying into it. If you have, call them, find out what you need to activate the case, find out what you're entitled to, find out how to get reimbursed. All of these things are important questions to know, and it pays to figure these things out while it's not under immense pressure, while you still have the time to be able to go ahead and do this. So we spoke about a lot of these things. Again, the JCC, where is the Holocaust program. So that's also an added benefit. So if anyone is entitled to that, you should certainly reach out to find out if you are entitled to those things. There's companion services out there where you can have people just be there with you. It doesn't have to be necessarily for care, just to have someone to be with you. Loneliness is something which is very difficult now, to stay overnight at a hospital maybe. There's the option to have concierge service. Again, I can only tell you what we do, where you would have people setting up all different types of appointments for you, any social work thing. Send you Harriet's number so fast. Again, make sure you take full advantage of OHEL in every way. They really are an OHEL, I guess it's just the best possible name for them. It's really excellent. They are such a tent that they encapsulate so much, and it's really something which is so special to be a part of in any way. COVID brings upon new challenges, and it has, and it will continue to for now, hopefully again, ending soon. But we should know that you are not stuck. you should know that there are things to do and there are things to prepare for this type of stage. Preparation is the key. You don't want to be stuck in that spot once it's there. But even if you are, also not the worst thing in the world, you can always reach out to people, reach out to Harriet, reach out to me, reach out to anyone who's able to help you in these types of situations. And hopefully, again, all of this will be what they say, halacha v'lo l'maaseh, that it will be not so practical, but it's important to be educated no matter what it is that you are doing. So with that, I will end, because we can go to questions if anyone has any questions. I am sorry if I just threw off the whole program.
No.
Good? Okay.
Everyone, thank you very much. I do have a few questions. I do have a few comments. One thing, Dr. Bekes and also Rabbi Schreier, if you could just put your email in the chat, because people have been asking for your emails. I know it was in Dr. Bekes's PowerPoint, but still people didn't maybe get it. So if you could put it in the chat so people could take it down if they have further questions that they want to ask offline, I just would appreciate that. So first of all, you guys both gave us so much information. I don't know. I don't think we'll be able to sleep tonight just trying to process everything that was just said in the last 2 hours. I mean, really, it's like, now I need to really think about everything. So I want to just talk about, I want to just answer a couple of questions, and also that will also, if anyone else has either question they want to write, and then afterwards maybe we'll unmute some people to see if they have any comments, if you're not comfortable putting something in the chat. So this is a question for Dr. Bekes, which was, how can we help our parents when we can't visit them in person?
Yeah, that's a good idea, and I'm not sure how original answer I can provide. So it's use anything that you can, like technology, phone calls, whatever works. It really, the regularity is important. So whatever you can do, if it's really just a 1 minute check-in in the morning by the phone, then that really means a world. So it's really important just to have this kind of really short, just something. And if possible, there should be a regularity so that they would know that, you know, this is at 8 o'clock, I will get a call and that will be it. And it doesn't have to be especially meaningful. I know that many times it's just there is nothing to talk about. So how are you? Everything is fine. Okay, but it's meaningful. It sounds like, you know, the why to do it. It is meaningful because there is that connection, there is the stability, there is the sense that you care about them. So this is what I can suggest.
It sounds good. At the end, I'll give our commercial for some of our programs. Another kind of question that people asked is, you know, you talked about the resilience, that actually our parents are more resilient than we are. So do you think it would be good for me to ask them to help us cope with all that's going on with COVID, or maybe like to give us stories? How did they manage during the Holocaust? Or like it's almost like I want to be an adult, but maybe they could be my, you know, like take care of me a little more.
Yeah, so in traditional communities, it's really common to ask the opinion of the elderly because they are wise. They went through so much that we haven't, and they see things in different perspective. So absolutely, I think that if we ask for their wisdom, it's really just beneficial for both parties. So it really expresses that kind of respect that we want to hear from them, that they are important, they can offer something still, and we can learn from this wisdom.
Okay, and then one other, I'm going to do the questions that people had written into me, is that I feel guilty that I can't see my parents, but I'm so afraid that I'm going to get them sick. And how can I respond when they say, why won't you come? Why can't you bring the grandchildren? Why can't you come? And I'm just afraid because I'm still working and I'm out there. And as Rabbi Schreier said, I want to keep them in the bubble because I can't deal with what if God forbid something happened. But they said, we don't care. We want to see you.
It's such a big dilemma, and it's a very common thing because we talked about well-being, and one part is the meaningfulness of life and purpose. And that's the meaning, to meet with loved ones, to see the grandchildren. Without that, you know, sometimes it feels that there is no purpose, there is no meaning. So that's a big dilemma. And I think that has always discussions about this and explaining how it works and finding some kind of compromise. I can see that point, and I can, my own mom has the same, approach, that they want, like, this makes life meaningful, that they meet with the grandchildren. So we find something to meet outside, or something that feels safe, and at the same time, so minimal risk, but at the same time there is that connection. So again, we have this technology. So if it at all possible to meet through the technology, through a glass door, outside, in mass, these are compromises, but I can see, and I think it's important to acknowledge that it's a justified wish, that, okay, there are health risks, but on the other hand, if you don't see the grandchildren, there are psychological risks. And that's important as well.
Okay. And then afterwards, I'm looking at some questions on the side, and now some of the questions are for Rabbi Schreier. So time to unmute you. So, you were talked about planning, and we need to plan. So when's a good time to plan? When
Right.
should children or family members bring up the topic of home care, or how should they bring it up? Like, just say, hi, let's have a conversation?
Right, it's an excellent question. Yeah, it's an excellent question. Probably the most common question I get all day, I probably should have mentioned it, is I feel like we need to start, but my parents will never accept anyone in the home, or stuff along those lines. They don't feel like they're at the same stage that we are. So it's on a few different levels. If it's coming from the kids, I feel like once their daily routine is being, interrupted, all of this is done with the utmost sensitivity, and, every family dynamic is different. But once, coming from the kids, at least, once it's starting to feel like, there's just a lot going on, and it's beyond maybe their purview of their visits, that they just can't sleep at night, that they feel like my mom can fall at any time, my dad can fall at any time, or something, just, I'm nervous about them taking their medicine on their own. I just don't feel comfortable. So when you start to feel like that, certainly something to look into. In terms of the patient themselves, it's a hard thing to, to kind of accept, but it shouldn't be viewed as some taboo thing. You can look into it while still healthy, and just understand what you're entitled to. If someone's been paying into long-term care insurance, I know I had the conversation with my grandparents recently, and thank God they're doing great, but they're like, oh, we have a great policy, wonderful. Like, you just should know what you're entitled to, what you're paying into. The other stuff, you have a basic understanding, a basic knowledge. Medicaid's out there, Medicare's out there. That's fine. You don't need to set up a home attendant for 4 years from now, or for 4 months from now. You should have a basic understanding of some of the general government stuff, and, see what's new and what's coming up, like the fact that Medicaid laws are changing nowadays and every second. But in terms of what you're paying into, you should certainly, should just be on top of that. Just know what you're entitled to and what you've been building towards for all those years.
Okay. I just want you to make one comment just about, because I just want to make sure people understand you talked about what a home health aide can do, but I think just talk, if you could address medication, because I think that a lot of families do get very concerned and confused about medication. So.
Right. So there's a lot of laws about who's allowed to administer medications for certain things. So a lot of times it would have to be a family member. We actually started sending out LPNs that are, a higher level of care. So it's a nurse practitioner, a nurse, or those are normally the people who are allowed to give medications. But what a home health attendant can do is medication management, which would mean, you set up all of the medication in whatever those trays. And yeah, exactly. Right. So you set them up in those ways, and you're able to make sure that they're taking the right ones at the right time. They're not allowed to administer shots or administer certain skilled care. That would need to be done by a nurse or a family member or an LPN, which again can be certainly arranged. But medication management, and that's a big deal for families that, if the patient has just a lot of pills that they would need to be taking, just to know that you have a set of eyes that's going to be double checking to make sure they're taking the right pills at the right time is a very big deal.
Okay. Let's see. Okay. I think that there was one question that someone had is, can an Offspring who has not arranged a home health care program be able to change the plan of care?
Mm-hmm. So I think if someone has home care and there's a plan of care there, so there's a lot of gray, in terms of what's on the plan of care, what's not. So, if they find that that's giving them an issue, that the aide's refusing to do something because it's not on the plan of care, so you just reach out to the agency, reach out to the nurse, and, they'll update things appropriately based on the needs of the patient. If the patient needs it, then it should be on there. So, no reason for it not to be there. So, so that's, I guess, the main. If specific question, feel free, to discuss.
I think sounds really important. I told you so much good stuff. If anyone has any questions, then they want to unmute themselves. I don't know if you can do it or if we have to. Maybe we can just unmute you for a couple of seconds to see if you could do this, and we'll go back. Any questions anybody has? Sarah, should we unmute them?
Yeah, I'm gonna unmute everybody.
Technology, you can't live with it and you can't live without it.
Great. So everyone, I'm gonna ask everybody to unmute themselves, but then everyone has to agree in order to unmute. So if anyone has any questions, please reach out. And
we have a few more minutes. We don't have to stay till 9:30. We really are probably on information overload at this point. And I just want to, while you guys might be formulating your question, I just want to say that at OHEL, and I do thank JFNA, that's Jewish Federation of North America, for funding our programs. OHEL has a special Holocaust grant for Holocaust caregivers and for survivors. Truthfully, before the pandemic, our program it's called At Your Door. We were funded to provide forums like this, but also to provide home visits, mental health visits, entitlement, social work visits to survivors and their family members. And we can go pretty much in the New York City area, Westchester, Nassau, as well as New Jersey. The pandemic actually changed our home visiting ability based on the fact that home visits are not really happening now. So we quickly figured out a way to do things with technology, to do things with the phones, we have done things on phones, on Zooms, all sorts of ways in order to, just like Dr. Bekes said, to kind of reach out to where people are, to kind of reduce isolation and to handle the different mental health needs that our survivors as well as our caregivers. So we can provide, and everyone should know, this is all free mental health services. In addition, I just have to say we're very excited and proud. And Sarah, and I know that there's somebody here on for sure on this call, we have caregiver support groups. Sometimes I was recently at a Shiva call and the caregiver was there and talked about the support we ran before and said, I thought I didn't need such a group. I thought I could handle what was going on in my life. I went to a group and then my children would say to me every week or every other week, Mom, it's time. You need that group. Get yourself there. And I saw how important it was. I wasn't alone anymore. And so I'm happy to say that we have been able to run 3 caregiver support groups. We do it either via phone or we do it over Zoom. Again, I left my email address on the chat. And again, if people don't know about the program, please call, ask questions. There is help out there. We are here. There's somebody here. If not us, we'll help you to find the right group, whether it be the psychologist, whether it be the home care agencies, the lawyer who will be here for the next time, Sarah Moskowitz, I see her name she's here. There are people, because we can't do it alone. And the wonderful thing about OHEL and all our colleagues is that we're doing this together. We might not be the best place for you, but we're certainly going to work hard to find this. And so I thank you all. Does anyone have any questions? So if no one has questions, you can either write it to us on an email and we'll certainly get back to you. This was recorded so that, hello, I see a question.
Hello, hi. I just have a comment for the professor. Can you hear me clearly? Yeah, you had made a comment that the Holocaust ended 75 years ago. And so the Holocaust survivors, the age starts at 75. As I was growing up, my mother is a Holocaust survivor, and among the Holocaust survivors, there was a huge differentiation between the survivors. The ones who are 75 years old now, some of them were born in the camps. Some of them were hidden in churches as babies. Some of them are not exposed to what the older ones were. My mother is one of the was in a camp. She was 14 years old, and the only reason she was kept alive was because she was experimented by Dr. Mengele. Otherwise, all her friends were sent straight to the ovens. And so they, amongst themselves, they differentiate who was in a camp and who, some people, and who was in hiding. There's a different degree of trauma amongst them. The ones who are in the camps had major trauma. They're even saying now that there are studies that the children have PTSD in their genes of these people, as opposed, like my mother has friends who did hide and were hidden in churches and were born in the camp. Now a 1 or 2 year old child cannot have that kind of trauma. The child does not know what's going on technically, So I just wanted to know what your opinion is on that, as far as, the different types of, because I think during the COVID crisis, I think I have a PTSD from my mother. And so I did take it it was not easy at all. Sitting at home and being at home, I was home with my mother, taking care of her. For 3 months, we did not go anywhere and, stayed home in the house. And we both had a very hard time. And there were others who really didn't have that effect, because of Holocaust, because they're a Holocaust survivor. I don't think so. Even as life goes, I had friends whose parents had different experiences. But like I said, the ones who were in the camps, those are like a minimum of 90 years old now. And so there is, I think that there is a kind of a difference, in between, the age groups and what they went through, and, and how it affected their families and their children, and how it affected now during COVID.
Yes, thank you for that comment. So there absolutely, you are absolutely right that there are huge differences in the experiences with the Holocaust, not only, based on what circumstances people survive. So obviously in hiding, that was somewhat better than being in the camps, or, some people managed to escape and it was not that traumatic. But I do think that the experience itself, no matter how someone survived, was that they were persecuted, that they were hunted down and they had to flee. So there was this traumatic experience. And even if you are talking about really babies, infants, really small children who didn't understand what was going on, based on psychological research, that's such a sensitive time that even if they don't know what was going on, they did experience this withdrawal from the parents and not having that basic attachment experience that all humans need in the first very sensitive time, especially in their lives. So it's just as traumatic, or even more. So just because they don't understand what's going on, being deprived from the safe, loving attachment environment, that's very, very traumatic as well. But I absolutely agree that these are very different experiences, and it's really hard to just put them all under one umbrella.
And the truth, if I can comment, we do see that people amongst our survivors, we've been doing this work for a long time. We've worked with many professionals who deal with trauma for second generations, the trauma they had. And you do hear people who say, my trauma is more traumatic than your trauma. And that becomes very hard. You even see this amongst the children. Well, my mother's trauma was more than your mother's trauma. And I think that, at least in my perspective and the perspective of many of our clinicians, we're here to listen. We're here to help. We're also here to validate. We're not here to get into a discussion on who was more traumatized. Because, we don't know, as Dr. Bekes just said, that 2-year-old who was maybe just born at the end, who did not have good attachment disorder, might have more traumatic experiences. And I always remember this. I heard this at a professional conference when I first started working at OHEL, when someone said, what kept me strong was I was 16 years old, but I thought about my parents' hugs and kisses. And even though there were bodies falling on top of me, I felt their hugs and kisses. And that helped to this person became a psychologist. It inoculated me against some of the harsh realities. Now, it didn't mean they weren't traumatized, but their coping skills, their resilience was in a way stronger than someone who did not have those hugs and kisses. So again, everybody's experience is so unique, and that's why I'm happy that we're able to provide forums like this, provide groups, and provide individual counseling, whether it be us or other services. And again, we really do have to look at the people who see that this is important. So JFNA and other kinds of organizations that say we need to care about the people in New York and in the different areas. So if there are any more comments, again, I want to thank everyone. I really want to thank our speakers. You did give us a lot of information. I think people are going to have to like really sit down, have a cup of tea, a cup of coffee, and just try to assimilate everything. I'm happy we have your email addresses. If people have more questions or would like other kinds of programs, really feel free to call on me at OHEL and call on any of my colleagues. And I wish you all a good night, a safe night. Tell your friends. We'll be back November 24th to have two new amazing speakers are going to be here. So thank you all and good night.